Good morning, good afternoon, or good evening, depending on when you are in the world, and welcome to today's microbiology webinar entitled Antimicrobial Resistance Innovations to Improve Detection and Prevention. My name is Zakaria Hadha. I'm the Microbiology Products Manager for Middle East and Africa, and I will be your moderator for today's session. So before we begin, I just have a short announcement. At the right side of your screen, you can see a question and answer box. Please click on it to submit your questions to our speaker at any time during the presentation. And now on today's session, our speaker is Dr. Jean Patel. Dr. Patel joined Beckman Coulter as Principal Scientific Affairs after nearly 17 years working at the Center of Disease Control, CDC, in the Antimicrobial Resistance Reference Laboratory and the Office of Antimicrobial Resistance. Dr. Patel, prior to that, was the Assistant Professor of Pathology and Laboratory Medicine and the Assistant Director of Clinical Microbiology at the University of Pennsylvania. Dr. Patel, over to you.
Thank you very much. I'm very happy to be with you today. I think we have some exciting things to talk about, ranging from antimicrobial resistant threats to new diagnostics. So let's get started. Today's presentation is Antimicrobial Resistance Innovations to Improve Detection and Prevention. This is a global public health threat. Antimicrobial resistance is a global public health threat. It is multifactorial. There are many different pathogens that are part of this threat. And in order to respond, we really need innovation. So that's what we're going to talk about today. And we'll talk about three different areas. The first will be a review of the kinds of bacteria that we worry about most when we talk about antimicrobial resistance. A group that tracks this is WHO, and they have recently updated their list of antimicrobial resistant bacterial threats. We're also going to look at the pipeline of antibiotics, are the drugs we need in order to treat an infection when it occurs. And again, we'll be able to get a glimpse of how robust the pipeline is and what kind of drugs are being developed. Then we're going to move on to an interesting subject, and that is microbiome management. Microbiome is a term that's used to describe just the normal bacteria in a certain environment. And in our GI tract, or in another word for this is in our gut, there are bacteria, and these bacteria are very helpful. We need this bacteria in order to live. It turns out that managing this microbiome could be very important in preventing infections in some circumstances, and we'll talk about that. And then we're going to review the clinical impact of some new antimicrobial resistant diagnostic tests that are in development or have come to market. And this will help us understand where these innovations have the biggest impact and what kind of tests we need in the future. So let's begin with the ranking of the antimicrobial resistant threats. We are going to focus on the list that came from WHO. There are other lists in other parts of the world, but WHO really is able to encapsulate everything that's happening in the world. Their list is focused on bacteria. And anytime you look at a list or a ranking of these kind of bacteria, it's important to understand the criteria that were used to rank the threats. So you really understand what this means for your population, where you live in the world, and also for yourself as an individual. The WHO list is there in order to guide research and development, the development of novel antimicrobial agents, and strategies for prevention and control wherever these threats occur. And the way they they rank the threats is by the number of regions in or number of WHO regions where the threat is either increasing or decreasing. And if there is an increase in multiple regions of WHO, well, that means that there's spread of the organism. Not only is there local increase, but then this increase is happening in different parts of the world. That might be because of global spread or just common drivers in different parts of the world that are allowing this increase to happen. This is a list that has been out previously, but there have been some significant changes to that list. And I think these changes are allowing us to focus more on the types of bacteria that we really, need to pay attention to. So there are now 3 critical antimicrobial resistant threats. And these are carbapenem resistant Acinetobacter species, Enterobacterales species that are resistant to 3rd generation cephalosporins, or we call them expanded spectrum cephalosporins. These are bacteria that might produce an ESBL or might have a plasmid-mediated AMP-C type enzyme. These are the types of resistance mechanisms that can cause resistance to the extended spectrum cephalosporins in Enterobacterales. And then there are Enterobacterales species that are resistant to carbapenems. Carbapenems are a broader spectrum beta-lactam than the cephalosporins. This is a drug that until recently we considered the last line drug, the most active drug that you could give to a patient with a resistant infection. We do have new drugs now, but we'll talk about how those drugs are active for some kinds of bacteria, but not for other kinds of bacteria. And that makes these drugs really hard to use. Well, this to me, I would say out of all 3 critical threats, this one I think is the highest critical threat. If we look at the group of bacteria that are ranked in the high group, these are the bacteria that have been causing antimicrobial resistant infections for a long time. An example of that is methicillin resistant Staphylococcus aureus. It's probably the most common antimicrobial resistant infection that occurs worldwide, but it is ranked as high rather than critical. And one of the reasons is because we have more drugs to treat that type of infection. There have been some significant movements here. One of them is Enterococcus faecium, vancomycin resistant Enterococcus faecium. This is an antimicrobial resistant infection that was most common in the United States. It really showed very low rates outside of the United States, but now there is an increase in the number of infections that are occurring in WHO regions, and it was given a higher rank because of that. What was given a lower rank are carbapenem-resistant Pseudomonas aeruginosa. This is a gram-negative bacteria, and when this bacteria becomes resistant to carbapenems, this is very serious. It's hard to find a drug that is useful for treating that infection. But what WHO detected through their surveillance system is that this type of resistance is actually decreasing. And maybe at the end of the presentation, we can talk about why that is a difference that you might see with that bacteria compared to, for example, the Acinetobacter bacteria. The bacteria that are listed as medium threats are group A Streptococci, Streptococcus pneumoniae, Haemophilus, and group B Streptococci. Let's look at some of the data that drove this decision-making for WHO. WHO has a global antimicrobial resistance surveillance system. It's called GLASS. And this is a surveillance system that collects antimicrobial susceptibility testing data from hospitals in different regions. It focuses on two types of infections. One of them is a bloodstream infection, and the other one is a urine infection. And these two infections were chosen because these are infections that are usually monomicrobial. There's a single bacteria there. It's really the easiest kind of diagnostic test for a microbiology laboratory to take up. So if there is a country that's just implementing antimicrobial susceptibility testing for the first time, they would probably focus on urine specimens and blood culture specimens. A lot of people would argue that a urinary tract infection isn't a very life-threatening infection and maybe shouldn't be the focus of surveillance. But what we have seen consistently is that new types of antimicrobial resistance are first seen in urinary tract infections before you see them in more serious infections. So this is a good way to identify new types of resistance. This graphic that you see shows trends in two types of critical antimicrobial resistant threats. The first one, the first column to the left, are the carbapenem resistant Acinetobacter species. And then to the right are the carbapenem resistant Klebsiella pneumoniae species. Anywhere you see white, that means that data were not submitted. So this is a challenge, right? There are whole parts of the world where data are still not submitted, but it is increasing. So you see more countries submitting data as years go by. So from the top to the bottom is the most recent data for WHO, and you see many more countries are submitting data, which is a really good sign. But you also get to see where data has been submitted, how these trends are occurring. You can see for carbapenem-resistant Acinetobacter species that this is a common occurrence in different parts of the world, and that there have been increases in resistance. You can see some changes in Europe and also in South America. For carbapenem-resistant Klebsiella pneumoniae, I think here what strikes me the most is not so much looking at the changes over time, because there definitely have been some gaps in the data. But if you look at the high rates of these infections in some parts of the world, so for example, in Australia, this is a really high rate of infection. And I would say that this high rate of infection is occurring in many of the countries that have not submitted data to WHO. This is a very common occurrence. There are multiple enzymes that can confer this carbapenem resistance. And again, these are the kinds of infections that are really hard to treat. So I want to take some time to talk about these bacteria. The critical threat bacteria, the three that I mentioned earlier, and some of the epidemiology of these infections. I pulled some data from the report that comes from the Centers for Disease Control and Prevention in the United States for these pathogens. Carbapenem-resistant Acinetobacter is identified as an urgent threat by CDC, so this is consistent with the WHO ranking. This is a bacteria that causes healthcare-associated infections. The bacteria has a unique ability to survive a long time on surfaces in a healthcare facility. And that means that almost every infection that is seen with this type of bacteria is the result of a healthcare-associated infection. And it can cause large outbreaks in a healthcare facility. CDC recommends that when an outbreak occurs, that there be very robust infection control measures implemented in order to get this outbreak under control. For example, CDC describes putting a patient in isolation. So if a patient is infected, they would have their own dedicated hospital room for them no other patients in the room. This is a pretty high ask, right? Not many hospitals have that kind of space for that isolation measure to be implemented. Yet these are this is how significant this infection is and how easily it spreads. In addition to isolating patients, it's important to really clean the hospital room. That has been critical in controlling any outbreak caused by carbapenem-resistant Acinetobacter species. These are bacteria that are resistant to carbapenems, usually because they have acquired carbapenemase. I think it's helpful to think about carbapenem-resistant Acinetobacter as a resistance that occurs because the bacteria has a carbapenemase. So every Acinetobacter isolate has a chromosomal beta-lactamase, which is normally turned off. So the bacteria is normally susceptible, but that gene can get turned on. So there could be expression of a chromosomal beta-lactamase that's causing the resistance. But more frequently, there is an occurrence of a plasmid-mediated carbapenemase that the bacteria has acquired. That means that the bacteria has an extra piece of DNA in it, a plasmid. That plasmid carries the carbapenemase. And what's really dangerous about this is that plasmid can hop from one bacteria to another. And we've seen over time that Acinetobacter species that are causing infections are more likely to have a plasmid-mediated carbapenemase. And that means that that plasmid is moving from bacteria to bacteria. And that is one of the reasons why this is a growing threat for infections. We'll move on to extended spectrum beta-lactamase producing Enterobacteriaceae. And these are described by WHO as Enterobacteriaceae that are resistant to extended spectrum cephalosporins. This is a really interesting phenomenon. This is a type of bacteria that when we first saw these emerging were a cause of healthcare associated infections. But the epidemiology of this bacteria changed. There were new strains of E. coli that emerged with these ESBL enzymes in them. And then the type of ESBL enzyme changed. So these enzymes used to be called TEM and SHIV. And now the most common type of enzyme is the CTXM enzyme. And it's really the E. coli that are carrying the CTX enzyme that are the reason for this increase. These are bacteria that are causing infections in the community. So it appears that this strain of bacteria that carry the enzyme are very good at populating patients in outpatient settings. These are the kinds of bacteria that will colonize your gut microbiome. And if you were exposed to antibiotics or anything else that disrupted your microbiome, you would see an increase in that number of bacteria. And that means you're at a higher threat for being infected with that bacteria. The most common infection caused by these bacteria are community-associated urinary tract infections. And just a good rule of thumb, when you're thinking about antimicrobial resistance, if it's a cause of healthcare-associated infections, and those are bad infections, but there are measures that can be implemented to prevent them. Measures can be examples of measures might be limiting use of a device like a catheter, cleaning hospital rooms, isolating patients. These are all measures that can help reduce the number of healthcare associated infections. But when antimicrobial resistant infections move into the community, the number of interventions we have really decrease quite a bit. And that's why you see this trend of infections that are shown by CDC. You see increasing number of infections over time. And that really represents spread of this pathogen in the community from one person to another. In the United States, this is listed as a serious threat. That's one level down from urgent. And I think the reason it is not the same as the WHO ranking is because this is a community associated infection. It's much easier to count infections when you're looking at patients in a healthcare setting. But once a patient is in a community setting, then counting those infections becomes harder. And it could be that we just don't have a good handle on exactly how many infections are occurring. Carbapenem-resistant Enterobacteriaceae, again, is listed in the United States as an urgent threat. And as I mentioned previously, this is the kind of infection that I would worry most about because it's very complex. This complexity makes it very hard to treat. Carbapenem resistance can occur when the bacteria acquires a carbapenemase or a plasmid-mediated carbapenemase. And the most common carbapenemase names are KPC, OXA48-like enzymes, and then the metallo-beta-lactamases, which are NDM, IMP, IMP, and VIM. Those are the types of carbapenemases that can be acquired to cause carbapenem resistance. But these bacteria can also become resistant to carbapenems without acquiring a carbapenemase. And this usually happens when the bacteria is resistant to extended spectrum cephalosporins and a change has happened in the bacteria, like loss of a porin. And that means there's less drug that gets into the cell, and the little bit of drug that does get into the cell can be hydrolyzed by the cephalosporinases that are present. The epidemiology of resistance is very different in different parts of the world. This is an example, a snapshot of resistance mechanisms from the United States, from Europe, and from China. And you can see in the United States, there are a lot of bacteria that are resistant without having a plasmid-mediated carbapenemase. And then when it is present, it is most likely KPC. In Europe, you see a different picture where the number of isolates not producing a carbapenemase are smaller, and you see more isolates that are producing the OXA48-like carbapenemase. In China, again, it is dramatically different. Here, almost all bacteria are producing a carbapenemase. By far the most common is the KPC enzyme, but they have a lot of bacteria that are have the NDM enzyme. This is the metallo-beta-lactamase. The metallo-beta-lactamase enzymes are super concerning because many of the new drugs that are coming to market are not active against these type of infections. So these are very hard to treat infections. So if we look at these three types of bacteria and we ask, well, why are these the three most critical threats? I think these are the characteristics that are important. One is they're gram-negative bacteria. Gram-negative bacteria, especially Enterobacterales, have been shown to be able to acquire plasmid-mediated resistance very easily, especially Klebsiella pneumoniae. That is a bacteria that can carry very large plasmids. These are big pieces of DNA. Most bacteria cannot carry a plasmid that is that large. But these big plasmids not only have a carbapenemase on them, but they have other resistant markers on them that can cause resistance to other drugs. A good example of this is aminoglycoside resistance. There is a trend where a plasmid with carbapenemase-mediated resistance is linked, has a gene on it that causes resistance to all the aminoglycosides. It's a 16S methylase gene. And that means it's an enzyme. It produces an enzyme that can modify any aminoglycoside. So now you have a single piece of DNA that when it moves from one bacteria to another, it carries two important types of resistance with it, and it makes infections very hard to treat. The other characteristic of all of these is that plasmid-mediated resistance is involved. The resistance is on a piece of DNA. It's represented by this little green circle in the bacteria. And that plasmid is able to hop from one bacteria to another. The example that's shown here is conjugation. That's a specific way that the bacteria move from one to another. There's also transformation. So there are multiple ways that these bacteria move and spread. This can happen in the microbiome, in a gut. So when you are carrying a bacteria with plasmid-mediated resistance, if you sample that gut microbiome over time, you can see that not only is the original bacteria still carrying that plasmid, but now there are other types of bacteria in the microbiome that also have that same plasmid. That is a way that antimicrobial resistance can really amplify by this plasmid moving from one bacteria to another. And then the third characteristic is that all these bacteria are transmissible. That means that the bacteria, which is represented here by the red stove, from one person to another. And this might happen directly, so there could be transmission from one person to another. It could also happen indirectly. And an example of this is at a hospital or healthcare setting, which is represented here. And the bacteria has hopped from the patient to a surface in the healthcare setting, and then from that surface to another patient. And that's how transmission can happen indirectly. All of these critical pathogens have these characteristics in common, and I think that's why they have become so widespread. So if we're going to have all these resistant bacteria, we need antibiotics in order to treat them. WHO again is tracking the development of antibiotics, and in a recent report, they showed how drugs are entering and exiting the pipeline. So the development of an antibiotic takes a very long time. It takes at least 10 years from the entry into phase 1 to exit in phase 3. And that's a very long time for drug development. A lot of things can happen during that period. So in 2021, there were 80 drugs in the pipeline. Over time, the next report occurred in 2023. Between those two time points, there were new drugs that were added, but there were also drugs that were exited from the pipeline. And the examples here are that the drug was just discontinued or removed, or the drug was developed but never advanced to market. And these are two of the highest risks that can happen during drug development. Actually, even before a drug candidate gets to phase 1, there are so many candidates that are weeded out because the drug is just never going to be distributed properly or in the human body or produces toxicity in the human body. But once it does enter phase 1, it can drop out again for other reasons: toxicity issues, safety issues, effectiveness issues. So we have had a net gain in the number of antibiotics in the pipeline, but it is a very perilous journey. There are more drugs in the pipeline that are available for critical gram-negative pathogens, and this is really where we need new drug development. Here you see the drugs being separated into two groups. One are traditional antibacterials, and the other one are non-traditional antibacterials. Some examples of non-traditional antibacterials are phage treatment. So phage are being investigated as a possible way to treat bacteria. There are novel chemical agents like peptides that are being used as antibacterials. And you will see some examples of probiotics. A probiotic is like a pill with healthy bacteria embedded in that pill. And that pill is used to help restore a microbiome that might be disrupted. So this is good news. It's also good news that we see an increase in the number of drugs that are being developed for critical antimicrobial resistant threats. An interesting thing to look at are the different classes of drugs that are being developed. Many of these drugs fit into drug classes that already exist today. Everything from the purple bar kind of below are novel agents, and there are just fewer of those. What you should really focus on is that first bar. Most of the drugs that are being developed are beta-lactam, beta-lactamase inhibitor combinations. That means we're taking beta-lactam drugs. These are the drugs we're familiar with as the primary effective agent in treating infections. And combining those with a beta-lactamase inhibitor, that inhibitor's job is to block the activity of any enzyme that might be present in the bacteria so that the beta-lactam can do its job. These are a very important class of antibiotics today. They're going to be even more important in the future. The problem is these can be very hard to use. And let's look at the next slide. This helps to explain why these are hard to use. So these are beta-lactam, beta-lactamase inhibitor drugs that are either on the market, the first few drugs you see are on the market, or in development. And then up across, you see the carbapenem-resistant antibacteriaceae and the different ways the bacteria can become resistant to carbapenems. What you should notice is that some of these drugs are active for some types of CRE, but not for other types of CRE. There's also carbapenem-resistant Acinetobacter listed there. That's the CRAB or CRAB initial, and then carbapenem-resistant Pseudomonas aeruginosa. Again, you don't see too many drugs either in the approved column or in the development column that are active against all these agents. These drugs are only active against some of the agents. Well, that means it's hard to use these drugs for empiric therapy. Empiric therapy, it means therapy decisions that happen before a diagnostic test is applied. Empiric therapy is something that's necessary because we have very few diagnostic tests that are super fast. And so doctors have to make decisions for life-threatening infections. And it can be very hard to pick one of these drugs as the right active agent for a patient. This, again, is what we have today. So a bacteria that has a KPC enzyme can be treated. You should expect activity with ceftazidime avibactam, meropenem vaborbactam, and imipenem relebactam. But if there's an oxa enzyme, the best drug is really ceftazidime avibactam. And if the isolate has a metallobeta-lactamase, the drugs that are going to be most effective are colistin and sulfidocol. Again, colistin is a drug that's not very effective. Sulfidocol is a drug that's really hard to test for antimicrobial susceptibility in the laboratory. This means that there is going to be a heavy reliance on diagnostic tests moving forward. Again, there are non-traditional antibacterials coming to market. All of the drugs that you see here have come to market. All of these are probiotic drugs. These are drugs that are there to restore a microbiome, the gut microbiome, when it's been disrupted. All of these have an indication for Clostridium difficile disease. That is an infection where disruption of the microbiome allows Clostridium difficile to overgrow. When it overgrows, it produces a toxin and it makes people very sick. Restoring the microbiome is critical to prevent reoccurring infections, and that's what these drugs are there for. These drugs could also be used for management of the gut microbiome, and that's what we're going to talk about next. So an important concept to understand is that colonization almost always precedes an infection and transmission from one person to another. We're going to talk specifically about the GI tract microbiome, but there are other types of microbiomes in your body. There's the respiratory tract microbiome. There's the urinary tract microbiome. There's the skin microbiome. These are all places where we have healthy bacteria that are helping us. But today we're going to talk about the GI tract microbiome because that's where many of these antimicrobial resistant threats first colonize a patient. So here we have an individual who is colonized with a multi-drug resistant organism. If that microbiome, the microbiome should be able to keep that intact because there's a lot of diversity in bacteria there. But if that diversity is disrupted because a patient is on antibiotics or has some other kind of illness, well, then that resistant bacteria can grow and overgrow and become the most dominant bacteria in the microbiome. When that happens, that patient is at a higher risk for an infection. And that's the patient who ends up in the hospital. They're also at risk for transmitting that resistant pathogen to other people around them. There are efforts to manage the microbiome as part of prevention for infections. One of these agents is that's under study is an activated charcoal tablet. This tablet is given at the same time that the patient receives antibiotics. And what this does is allow the antibiotic to work outside of the gut. So the pill, the charcoal pill that's taken, that travels to the gut. And there it absorbs all of the antibiotics in the gut so that the bacteria aren't killed off. You still have high concentrations of the drug in the bloodstream, and that allows the antibiotic to be active at the site of infection. So this is a strategy that can be used in order to prevent the microbiome from being disrupted. This has been tested with fluoroquinolones, and there's a nice paper in the literature describing that it protected disruption of the microbiome. If a microbiome is disrupted, there is a strategy for restoring it, and that is giving the patient probiotics in order to restore the microbiome, give the patient back the diversity, bacterial diversity that helps to keep these resistant bacteria in check and prevent them from overgrowing. These probiotics, again, are available for preventing reoccurring C. difficile infections. But we expect that with additional studies, these will become more widely used for preventing infections. You can also manage the microbiome by preventing colonization. You can think about these E. coli that are causing urinary tract infections as an example here of where community protection would be important. A patient in the community can become colonized with a resistant bacteria if particularly water sources around them are contaminated. Water sources can be contaminated wherever antibiotics are used. Antibiotics are used in the hospital. There is hospital runoff that can release antimicrobial resistant pathogens into the environment. Antibiotics are used on the farm for food producing animals. That antibiotic use and resistant pathogens can run off into water sources. Antibiotics can be used as a pesticide for crops, and for example, for apples or other kinds of produce. that is a place where antimicrobial resistance can occur and run off into the environment. When it is in the environment, then it is more likely to colonize patients. And again, I think here a good example of this are the ESBL producing E. coli. There was a recent meta-analysis of the occurrence of colonization with ESBL E. coli for patients in the community. And globally, there's been an 8-fold increase in the number of patients who are colonized with this pathogen. And I think that's an example of just how common these bacteria are in our environment. So for all of these, really, the root cause is use of antibiotics as a driver for antimicrobial resistance. And there is a focus on improving antimicrobial use. This is a primary prevention tool that can be used to decrease the number of resistant infections. The strategies here are education. This is necessary not only for the prescriber, but also for the patient, understanding when antibiotics are needed and then which ones to use. There are audit feedback strategies. This is a strategy where data is kept on the number of prescriptions that are happening, what kind of prescriptions they are, and then benchmarking this against other similar kinds of practices, situations, and being able to identify where overuse of antibiotics might be occurring and giving that feedback back to the prescriber so that they can adjust their prescribing behavior. And then one of the most important things in improving antibiotic use are diagnostics and making sure that you have very robust diagnostics. And so we're going to talk about some innovations in diagnostics that are going to help with improving antibiotic use. We're going to talk about identification of genes encoding carbapentamases in rectal specimens, rapid detection of pathogens from whole blood. This is directly from blood. This is before incubation in a blood culture instrument. There are tests coming out with that. There's rapid genotypic detection and antimicrobial resistance detection from positive blood culture. And then finally, rapid phenotypic AST directly from positive blood culture. We're going to look at the clinical impact of some of the tests that are on market. This first test is detection of carbapenem resistance encoding genes in a rectal specimen. The test here is the Cepheid CARBA-R test. This is a PCR test with results that are available in about 15 minutes. This is a test that is able to detect KPC, OXA48 enzymes, and then the metallo-beta-lactamase enzymes, NDM, IM, and BIB. This is a test that would identify a patient who is colonized with a carbapenemase producing bacteria and might require enhanced infection control procedures. And there was a study, a 6-month study, that implemented this diagnostic test as active surveillance in an intensive care unit. Active surveillance means that this test was given proactively to patients to identify colonization. And then when these patients were identified, they were put in isolation. This isolation of patients led to a reduction of both colonization and infection rates during the study period. And so this is a way that you can use a diagnostic test to prevent infections. Here in the United States, this is the only test that's available for preventing infections in patients. Let me move on to tests that can be used to detect pathogens from whole blood. The T2 test is an example of this. There is a version of this test on the market for Candida detection from whole blood, but there is also a new test for detecting bacterial pathogens and for detecting resistance. And these can detect bacteria that are the most common types of resistance. This is a test that you can used to identify very early, identify pathogens that are causing very severe infections, and it can be used to make treatment decisions. The sensitivity of this test is at 90%. So that means when you're detecting the pathogen from the whole blood, 10% of the infections might be missed. But it is very specific, high levels of specificity. In a study, the time to results is about 40 hours. 40 hours less than a traditional workup for a blood culture specimen. So that means that if you implemented this test, you have the potential to get an answer 40 hours earlier than you normally would. Well, that's a huge benefit in order to get that result very early. The challenge is that the test does not detect every infection rate, and so that can impact the ability to manage a patient using one of these tests. In one study, 38 sepsis episodes were tested using this test. 10 were positive, 25 were negative, and 3 were invalid. Resistance was detected in 4 episodes, and changes in therapy occurred in 8 episodes. So that means that out of the 38 cases where the test was applied, a change in management occurred in only 8 of those patients. Well, that could be really critical for those 8 patients, very important for those 8 patients. The challenge is understanding how to use this test to maximize the ability to drive therapy for all these patients. One of the real challenges here is that there are very low bacterial counts in the blood, and applying a diagnostic test directly from blood without incubation is a hard thing to do because there are so few bacteria in order to detect and characterize. There is direct from positive blood culture testing. The BioFire BCID test is an example of this. It can detect pathogens. It can also detect resistance mechanisms. And there are results in about an hour after detection. So again, this can be used to guide, this can be used to adjust and empiric therapy decisions for a bloodstream infection. Again, the time to optimizing therapy is reduced to 4 hours and 39 minutes. This is the median time in a study where this test was applied. This is much faster than the traditional workup of a positive blood culture specimen. This, in a study evaluating the clinical impact, this test led to treatment modifications in 32 out of 100 episodes. 25 were adjustments where there was an adjustment to optimal therapy. And the remaining 9 episodes were an adjustment that required additional ID and AST testing in order to get the optimal therapy. So this can be a challenge for a test that's resistance mechanisms rather than antimicrobial susceptibility. Resistant mechanisms are useful for telling a clinician what drug is not going to work, but those tests cannot tell a doctor what drug will work. And that limits the number of patients that are going to receive optimal therapy as a result of the diagnostic. Rapid phenotypic susceptibility testing has the potential to overcome this challenge. This is a test that's on market. It's the Accelerate Pheno. It has a 7-hour time to result, and it can perform bacterial identification and susceptibility testing. Again, this is used to diagnose directly from a positive blood culture specimen. In a prospective randomized clinical trial, the median time to optimal antibiotic modification was faster than when the test was not used. So there was optimal therapy decisions performed at 8.6 hours on average versus 14.9 hours for those who had the diagnostic and those who did not have the diagnostic. In a retrospective study where many more patients were tested, the length of stay was shorter by 6.3 to 6.7 days for the patients that had the diagnostics. A retrospective study is a study where you ask, it's a hypothetical study where you ask, if I had this test available for my last 830 patients, would it have made a difference? And that is where you're able to pull out these length of stay impact outcomes. And I think it's because you're able to study many more patients than you would in a prospective clinical trial. Discrepant results occurred in 28% of the infectious episodes, resulting in incorrect antibiotics stewardship prescribing practices for 14%. So this is a challenge with any diagnostic test that is rapid. When there are inaccurate results that are produced by the diagnostic test, this can result in changes in therapy recommendation. The good news for this study is that in all of these incorrect changes that occurred, there were no differences in clinical outcomes. I think the challenge for use of this test, though, is the clinician who might not trust the test and might make a decision to not change antibiotic therapy, not improve antibiotic use because they don't trust the diagnostic test. All of these tests are good diagnostic tests. They're all rapid. They all have a very specific application. But we need more improvement in order to get the kind of diagnostic tests that are really going to impact antibiotic use. Here are some takeaways from my perspective. Impaired treatment decisions for bloodstream infections require accuracy. These are life-threatening infections. A doctor doesn't want to make a change. They don't want to de-escalate antibiotics or switch to a new antibiotic unless they have confidence that this is the right decision. Detection of resistance mechanisms is a way to get a rapid result. But these test results are limited. Like I mentioned, they tell you what drugs not to use. They don't tell you what drugs you can use. Rapid phenotypic susceptibility testing can reduce time to optimal therapy by about 24 hours, and this is really important. This test has the potential to replace conventional AST. If we can perform rapid AST in less than 7 hours, well, why wouldn't we want to do that for every specimen? And that's the kind of diagnostic test that we should all want and expect. For that to happen, it really has to be an affordable antimicrobial susceptibility test. Another important takeaway here is that diagnostics can be used to prevent infection, and CRE prevention is possible when diagnostic tests are performed. So a few conclusions, and then we'll move on to questions. If we talked about a lot of different things today, and if we put this all together, the important thing to understand is that antimicrobial resistance is not a future threat. It's a threat that's present here today. There was a very important Lancet study that measured mortality across the globe from antimicrobial resistant infections. And there is not a place in this world where mortality rates aren't increasing because of this public health threat. Again, this is what we have today, but the problem is growing, and we have to be able to address it. Addressing this problem will require multiple sectors. It requires paying attention to the patient in the hospital making sure resistant bacteria aren't spread outside of the hospital, and making sure that our environment is free of antimicrobial resistant threats so that they aren't leading to future infections in our population. I think the Public Health Agency of Canada has a really nice graphic that really describes how we have to have this holistic view of antimicrobial resistance and how we address it. With that, I will wrap up, and I do want to share with you our vision at Beckman Coulter. Our vision in microbiology is accelerating innovation to improve antimicrobial therapy decisions for every patient. We are laser focused on innovation and making sure that our customers have the best diagnostics for improving antibiotic use for patients. And I look forward to speaking more about this in the future.
Thank you so much, Dr. Thank you so much, Dr. Jean. Thank you so much for this great presentation. And now on the Q&A session, so just a reminder, you can still submit your questions at the right box of the Q&A session. So let's start with the first question here from Inuma from Nigeria. So can you talk about the effect of inappropriate treatments when it comes to AMR? So briefly, Dr. Patel, because unfortunately we are running late out of time. So.
Sure. So for a very serious infection, an inappropriate treatment can be a life-threatening situation. If the decisions the doctor can make are to de-escalate antibiotics, that means not use as many antibiotics for treating that infection. And if that is the wrong decision, that can be a life-threatening decision. Again, the other decision the doctor has to make is should the patient be moved to a more active agent? That agent has to be the right active agent. And again, because of the new drugs that are coming to market, picking the right one is a challenging choice to make and needs to be guided with robust, accurate diagnostic tests.
Thank you. Thank you. So second question from Dr. Misgana. It's about the magnitude of multi-drug resistance and how to combat it.
So the magnitude can be overwhelming, especially in certain parts of the world. It really is going to require decisions at the patient level, at the institution level, at the government level, and at the global level. The United Nations is focusing on this topic at the next General Assembly meeting. And this is an opportunity to really make sure that all sectors are looking at interventions that can be effective at every level.
Thank you. So another question from Rehab asking about the next, let's say, generation therapeutic options. And if we have any proof about the effectiveness of those, like, for example, enhancing the microbiome of the body in order to be able to fight the pathogens that you listed in the presentation.
Yeah, there are some very exciting antibiotics that are coming to market, drugs that could be quite effective. I would say that these are in very early stages of development. If you look at the WHO pipeline, there are drugs that indicate activity against all carbapenem-resistant gram-negative infections. There are some very good Staphylococcus aureus drugs that are coming to market, ones that have higher potency than vancomycin for killing that bacteria. Again, that's a really common kind of infection, so having a new drug there is super important as well.
Thank you. So Christian is asking about the activated charcoal and if there is other use of this for the management of transmissible diseases.
This is an interesting therapy that is still in development. And I think as the drug is developed, there will be opportunities to look for other uses. I think it's a very innovative solution. I get really excited when simple things like activated charcoal pills end up being an effective solution. So I look forward to learning more about this. It's still early days.
Thank you. So there is another question. Yeah, another question from Thomas asking about Acinetobacter baumannii and the fact that it can survive longer on surfaces. So, is it mean that this pathogen can be considered as hospital-acquired infection?
Yes, yes. In fact, it is a hospital acquired infection. That is where the risk for this pathogen occurs. Stopping outbreaks in the hospital are very hard to do. It requires multiple interventions, mostly cleaning the environment in order to rid the environment of this bacteria because it does survive so well on surfaces.
Okay. So another question from Marie Pitt asking about the diagnostic procedure to identify not only bacteria but also yeast, but also fungi. Sorry, and I think here she's referring also to some of the innovations that you mentioned during the presentation.
Yes, so it is important to have diagnostics for fungal pathogens as well as bacterial pathogens. T2 is a company that has tackled that. They have a test that would span those different types of pathogens. I think you'll see rapid phenotypic susceptibility tests that also address both fungal and bacterial pathogens in the future.
Okay. Okay. So just to mention something, because we have received some questions about sharing the presentation and the slides. So please, to the audience, once you are completing your steps required for the webinar, you will receive after that an emailer with the video recording, so you can watch it on demand later. So last question here, because unfortunately we are running out of time. Can you briefly talk about the IMR in hospital-acquired infections and effective therapy option? This question also is coming from Christian. Another Christian, I think, different from the first one.
And IMR, I'm not sure what the IMR is.
So antimicrobial resistance globally when it comes to the hospital-acquired infections, and what are the different therapeutic options that we can use to combat that?
Oh, thank you. Thank you for that. Healthcare-associated infections, today impaired treatment decisions for any infection are really focused on, so for example, cephalosporins are still used for primary therapy in some parts of the world. Making decisions to expand to a more active agent then would require a diagnostic test. The tests are used to drive changes to antibiotics, like for carbapenem-resistant Enterobacteriaceae, the choices might be imipenem relebactam, ceftazidime avibactam, and meropenem vaborbactam. These are all drugs that are beta-lactam, beta-lactamase inhibitors, and they would have enhanced activity for some of these pathogens.
Great, great, great. Thank you so much, Dr. Patel, for the insightful presentation. It was really good. Thank you so much for all the participants, attendees, those who submitted the questions. So thank you for the level of the engagements. Just a quick note, we really appreciate if you can participate and submit your opinion for the short webinar survey before leaving. So thank you so much all, and have a great day. Thank you.